Thanks, guys. Thanks for the introduction. So I'm going to talk about updates on venous thrombosis and pulmonary thromboembolic disease. I'm actually going to go really fast with the DVT stuff because I think Dr. Ting and Dr. Kim did a good discussion about it. So again, why to treat? I think Dr. Kim explained that very well. You want to prevent ulcers. Conventional therapy, unfractionated heparin, DOACs, they're great in terms of stabilizing their symptoms, but doesn't really prevent some of these sort of long-term venous stasis problems, and we've seen that very well. So why pharmacomechanical thrombectomy? I think thrombolysis alone has some drawbacks, long infusion times. The mean duration time for infusions in the venous registry, all this was many years ago, was about 48 hours. There's a bleeding risk, obviously ICU stays depending on where you are. I think now, if I gave this talk 5 years ago, there was probably 1 or 2 devices available for doing DVT interventions. Now, I'll be honest, I can't even keep track of how many different devices there are for venous thrombectomy. So, I put this is from 5 years ago. This doesn't actually even appropriate anymore. So the first one that was out there was the angiojet catheter. I think, it has its pluses and minuses. I think all of the catheters and devices are good. I think they're all equally as effective and equally as dangerous, depending on how you use them. So if you're comfortable with them, I say by all means use whatever you want, because I think they're all about the same in terms of their ability to remove clot. They all have their pluses and minuses. We all kind of know how the angiojet works. It's been around forever. There's the penumbra catheter, which was sort of like the next big device for DVT. It's gone through its iterations. They came out with an 8 French device, and then they moved to a 12, and now to a 16. They've added lightning and bolt and all these sort of bells and whistles to this device. So again, I would recommend definitely going to the booths and seeing how these devices work, because you'll sort of get a sense of how these things work. And again, they use the sort of now clot detection to mitigate the blood loss. So as you go up to 16 French, your blood loss is going to go up exponentially. So you can't just have an open hose to suck out clot. You'll just bleed them to death. So, even with these bigger catheters and with this new clot detection and blood mitigation, you're able to keep your blood loss sort of in a reasonable state. So I'm actually going to skip the cases because they're actually not super interesting. You guys will get the slides, but basically you're able to suck the clot out. These catheters are super maneuverable. You're able to remove clot very, very efficiently. And do these cases sort of in a one-step, one-sitting kind of case. There's the Inari device, again, which is sort of another good device. It's basically a big cage and a coring element to sort of grab clot and bring it back. You're sort of obligated to either do it from a popliteal approach, or if you have iliofemoral clot and no common femoral clot, you can do it from a common femoral vein approach. But again, it is pretty effective in removing clot. I like it sort of more for chronic, sort of free-floating clot. There's a patient with, as you can see, sort of clot floating within the IVC. These other sort of suction devices would be a bit hard to do that. Here's the IVUS. You can see sort of this chronic clot sitting in the IVC. I find IVUS for these cases very helpful. You can actually use IVUS. So this is the IVUS sort of staying still, and then we're just bringing the device around. You can see the Inari device coming around and grabbing the clot. So I find this super, super effective in removing it. This sort of in 1 or 2 passes, we're able to get this clot out very quickly and efficiently. And this is kind of what it looked like for this patient. Sorry, this video doesn't play, but this is sort of the stuff we got out. So, suction catheter isn't going to really get that kind of chronic stuff out, or you'd have to do something very big like an angiovac, which requires like veno bypass and things like that. So here you can be able to do this. This patient was awake during the procedure. It doesn't require sort of higher end care. One of the newer devices, the Symphony device from Imperative Care. Again, it's just very similar in sort of the penumbra device, but it has sort of that hand switch that you can go back and forth to remove clot, and that sort of mitigate blood. It's kind of flexible. Again, for these devices, you don't want to stay still. You kind of want to sweep them and move them in very quickly and go through these cases. You just don't turn it on and just run it. You just sort of have to do it. And you're able to remove clot very efficiently in these cases, and this patient did well. There's the Asprex catheter. So this is actually what I'm going to spend most of my time on is the PE stuff. So how many people are doing PE interventions in their training now? So decent amount. Okay, so PE, basically the ones we're going to intervene on are the submassive or intermediate risk patients. And we're going to really sort of move more to the high risk submassive patients, so RV strain and some sort of positive biomarker. And that's probably going to change as well, but that's sort of how we're going to look at the world. Obviously, the high-risk patients, there's no question these patients need some sort of intervention, and then it becomes a fight between either do they go to surgery or do they come to the angio suite. And this is sort of a breakdown of how these patients sort of present. So this is sort of our typical protocol example, right? So PE is diagnosed. Is there shock? yes, then it's most likely high risk. You're either going to push IV TPA, they're going to go to surgery, or they're going to get some sort of intervention. Usually these patients you just can't sit on. If they don't have symptoms of shock or hypotension, you're going to go down sort of this S-PESI score thing. So is their troponins elevated? How bad is their RV function? And then you're going to sort of stratify them. Are they going to be intermediate to low risk patients? I think if you're going to do PE, you should probably do it within the framework of a PERT team, a PE team. So you can't really do this in a vacuum. So you need sort of all the sort of stakeholders to be in it. And I think there's good data to show that within a PERT team, the patients tend to do better than trying to do this sort of in an isolated function. So PESI score, just so you guys know what it looks like, this is what it is. There's the sort of more simplified PESI score, and then so you can sort of see what that basically means in terms of 30-day mortality. There's a simplified PESI score, and that's pretty straightforward there. So there are multiple single-arm device trials looking at acute performance of all these things. Obviously, some of this stuff is based on an old New England Journal article from, 2008, 2007, where they were pushing IV TPA for these intermediate risk, high-risk PEs. They were looking at mortality. I think mortality is going to be a really hard endpoint for a lot of these studies and a lot of these devices. It's just not going to work because I think you're not going to let patients die, so you're not going to do mortality-ending studies. So all these studies do RV-LV ratio as a marker or as a corollary to basically, are they at high risk for mortality? I don't like imaging studies for endpoints for studies, which is weird because I'm a radiologist, but I don't think it really, we're going to tell patients, oh yeah, we're going to make your RV-LV ratio better. It doesn't really mean anything to anybody. So I think really the newer studies are looking at long-term clinical improvements, and some of the newer studies, which I think are going to be more impactful, are looking at randomization between intervention and AC plus AC versus AC alone. There's the STRIKE study, which again has looked at, has already enrolled probably a little bit more than 600 patients, looking at acute PE. This is not a non-randomized study. It's sort of more like a post-market registry, but again, showing you have significant reduction in RV-LV ratio in these patients. We can do these. The sweet spot for these interventions is, can you do them safely in under an hour without the need for general anesthesia? And I think for almost all the devices that are currently out there, I think we can fit those criteria. Now we just got to figure out which of the patients do we need to intervene on. So I'm going to spend a little time on this slide specifically. So these are sort of all the sort of ongoing trials. HiPytho is done, so we'll start with that one. So HiPytho was looking at ECOS, and they basically randomized patients to either 1-to-1 ECOS versus anticoagulation alone. And they actually picked patients who were relatively sick. So they were intermediate high-risk patients, but they used something called a NEWS score, which is a little bit used more in Europe than it is in the US, as a way to stratify patients. So they took patients who were tachycardic, had bouts of hypoxia, or hypotension. They couldn't be hypotensive going into the study because that would still be basically considered a high-risk PE patient. But if they had an episode of hypotension within a certain time frame from enrollment, and then they basically tried to get these patients on the table relatively quickly from the time of randomization. That study is done enrolling. So it is looking at PE-related mortality. Ultimately, I think that's going to, from that endpoint, it's going to be a negative study because it allowed patients to cross over. So you didn't have patients who were on the AC arm who were going to die because they could cross over to an intervention if they decompensated. We know patients decompensated. I think the study's going to be positive. We'll see how positive it ends up going to be. That study should actually get published hopefully within the next few months, either TCT, Viva, or it might end up getting pushed a little bit further than that. Peerless is looked at basically FlowTriever versus CDT. And basically what they found, that one's actually done as well, what they found is actually patients required less time in the ICU, but they end up doing clinically about the same. PE Tract is an NIH randomized study. I think they're about 3/4 of the way done enrolling in the study. It's about 500 subjects of 30 North American sites. Basically, it's taking actually every intermediate risk patient, so whether they're high risk or low risk, the only inclusion criteria is RV-LV ratio. They're going to follow these patients out to a year and really look at sort of their functional abilities at a year. So are we making these patients feel better faster? Are they able to get back to work quicker and get back to their normal state of life? STORM trial just enrolled, so that was 100 global subjects looking at a 1-to-1 ratio between intermediate high risk, and again, they didn't have, those patients were a little bit less sick than the patients in the HiPytho study, and looking at RV-LV ratio at 48 hours, PE-related mortality, cardiovascular decompensation, and then they actually have some other arms of that study which are going to come out later. They gave patients wearable devices to see how their functional status was after the procedure, and they're going to follow these patients out. That should actually get, I think they're planning on presenting at Viva, or actually maybe TCT this year. Peerless is currently enrolling about 1,200 patients looking at the Inari device, 1-to-1 for anticoagulation, and then HiPytho 3, which is going to come later. So the PE devices, I'm not going to spend a lot of time on each of these devices. I'm not even sure if these slides are even up to date anymore, because I think 2 or 3 devices got approved within the last few weeks. So there's the ECOS device, which uses TPA and uses ultrasound to break up the clot. There's Inari FlowTriever, which comes in a 24 or 16 French flavor. It's actually 20 French flavor as well, to go in and suck blood. They have a blood return system. It works pretty well, very well. Lightning is the Penumbra device. There's the AlphaVac system, which is from AngioDynamics, has a funnel and a handle. And that's sort of the way you control blood loss. There's the Bashir catheter from Thromboembolics, which is basically, looks like sort of a cage that has like little infusion ports for TPA. It's used to both basically macerate the clot as well as inject the clot. They have a trial ongoing to look and see about the potential of doing an on-table infusion. So basically, you deploy the device, inject TPA, infuse, twirl it around, move it to the same device to the other side, and do the same thing, and then get them off the table. Symphony just got approval for their 24 French device, and again, that has a handle and a switch to basically control. So it has, you can see here, there's like this switch here. So the blood gets sucked into here. So it's basically charging this area with a vacuum, and then when you turn it, you get sort of the whoosh, and then it captures the blood there and the clot there. Aventis from Inquis is coming, so that's actually on study, and I clearly have missed some more, because I think there's at least 2 more devices out there. How we do PE at Mount Sinai, all through a PE team, we use AI doc for clot identification, and all procedures are performed with anesthesia for cardiovascular support, depending on the patient, plus minus cardiac anesthesia. Usually anesthesia is there just to really handhold and make sure they don't die. They're not really giving them any anesthesia. And these are sort of the cases. So this is a patient with a submassive PE and a big saddle embolus. You can see here is the PA-gram. You can see clot here. This is with the device. We were able to get some of the device. And again, the idea here for these procedures isn't to remove all of the clot, is to get them off the edge and try to remove as much clot as we can safely in a timely fashion. And this is what the patient's CAT scan looked like 48 hours after. And you can see, even though we didn't get a great on-table result, we got enough of the clot out, and the patient was able to autolyse the rest of their clot on their own. There's another patient, we used the Inari device, again, a big saddle embolus here. This is the before, after with the Inari device. We're able to get sometimes you're able to get these big chunks of clot out, and these patients do very well. So single session DVT treatment can be performed reliably, excellent safety profile, no ICU stay, like I said, multiple different devices, all of them which are safe. Just got to figure out which one works best for you. PE treatment is advancing. I think the safety profile is greatly improved. No real difference right now between the devices, and then we're going to see lots of studies coming in the next few weeks. So it should be great. Thanks.